Welcome to the Fit Strong Women Over 50 podcast, episode number 178. Hi, I'm Jill. Thank you for joining us today.
And I'm Chris. Jill and I are the hosts for this podcast and the founders of the Becoming Ellie community.
If you're wondering why we decided to name our community Becoming Ellie, it's because Ellie was the Norse goddess of aging who beat Thor in a wrestling match. Chris and I thought, hey, we want to be like Ellie, fit and strong as we age.
Yes, that's so true. You can find out more about the Becoming Ellie community and this podcast at our website, becomingellie.com. And Ellie is spelled E-L-L-I. You can also sign up for our newsletter while you're there.
Today, we're learning about continuous glucose monitors and how to figure out the best way to eat. Let's go to the podcast. Dr. Paul Kolodzik is board certified by both the American Board of Preventive Medicine and the American Board of Emergency Physicians. In a 30-year emergency room career, he has cared for many patients in crises and has witnessed firsthand the failures of mainstream diets and the medical system overall, which prioritizes medications and surgery over diet and lifestyle changes to prevent and reverse disease.
In his metabolic health practice, Dr. Paul uses technology of continuous glucose monitoring, also known as CGM, previously only used by diabetics, to help his patients achieve weight loss and improved health. He also has integrated the prudent use of the new weight loss medications into his practice.
His new book, The Continuous Glucose Monitoring Revolution, presents a comprehensive program for metabolic health success using CGMs and limited use of weight loss medications.
Dr. Paul graduated from the University of Notre Dame and completed medical school and residency at Wright State University, where he served as chief resident. He's a founding member of the Society of Metabolic Health Practitioners.
Welcome, Dr. Paul. We're delighted to have you here today.
And it's great to be here. I've been looking very, very forward to this because as we were talking briefly, you know, your demographic is my demographic. So, I look forward to the conversation.
Great. Thank you.
Yes. So you are an emergency room physician for over 30 years, and now you deal with metabolic health. That's a big transition. Can you tell us what prompted you to make that change?
Yeah, it does seem a little bit incongruous at first, emergency medicine versus long-term preventative health. But basically what happened is that I realized in the emergency department that the metabolic health issues that we see were the majority of what we see every day. What gets all the news in the emergency department is, the overdoses and the multiple traumas, the big trauma cases. But what we see every day in and day out, is metabolic disease. And it largely has to do with blood sugar metabolism that leads to diabetes, because now 45% of American adults either are pre-diabetic or diabetic. And it has to do with the sequela of blood sugar issues, which is obesity. In the emergency department, I would see the renal failure, the kidney failure, the peripheral vascular problems with people losing their legs, the heart attacks, the strokes, the other blood sugar, diabetic emergencies, infectious issues. So that's what really motivated me to get ahead of this by opening the metabolic health practice about 7 years ago and helping people prevent those problems. Because we've kind of been led down the wrong path here over the last 50 years, really, in terms of what we need to do with diet and activity. And so in my practice, I help patients understand blood glucose physiology and how to improve it. And that often leads to disease reversal and weight loss.
Okay, so I feel like there's a lot to understand here. So let's maybe just start with what is metabolic health? And you've mentioned a number of, I guess you would call them diseases, of things that fall under that, but maybe you could describe it a little more for us?
So in its simplest sense, metabolic means how you take in energy, basically what you eat, and then how you expend that energy. What are your activities, including workouts and that type of thing. I'm going to give you a little bit of background because it has to do with my philosophy on how we need to approach improving metabolic health. Because when you don't have that energy intake and output balance, the result is that you basically gain weight, and it spurs diseases like we talked about: prediabetes, diabetes, hypertension, other vascular diseases. So the philosophy is this: if you'll bear with me for a little bit, if you think about it, if you look at photographs or movies from the 40s, 50s, early 60s, you didn't see obesity. Very rare that you would see people in those movies or those photographs that were obese. And then the food pyramid came out in the early 1970s, and we were told that really grains and carbs had to be the foundation. As you'll find, I'm a low carb person. I very much believe in that. We can get into the details of why I believe in that. But, the food pyramid came out, and instantly overnight, we went from 50% fat in our diet to 25% fat in our diet because we were told cholesterol was evil and we had to stay away from fat. And at the same times, our carbs went from 25% up to 50%. I believe it's unmistakable that with that change, which of course the food processors got on board with after the U.S. Department of Agriculture posted the food pyramid and we began to educate people about it, it's unmistakable that the epidemic of obesity took off. And then 10 years after that, the epidemic of diabetes took off. And so I think there's a direct relationship there. So when we talk about people going low carb diets, and we can talk about the difference between low carb and keto, I primarily just have my patients on low carb diets. Basically, we're talking about going back to the way Americans ate for many, many generations, hundreds of years prior to the time we were told that we needed to eat more carbs. And so there is this balance here, as you might expect, between a low carb versus a low fat diet, and then what's going on with your blood sugar versus what's going on with your cholesterol. And I think for most people, blood sugar physiology is a much, much bigger issue than what's going on with your cholesterol level.
Interesting. Yeah.
I think we've had way too much emphasis on cholesterol. Blood sugar problems have run wild during this period. Basically, my practice is working with people to understand that physiology and then gravitate back toward a lower carb lifestyle. I believe calories in, calories out is not sustainable for a lifetime, but I believe a low carb lifestyle is embraceable for a lifetime. And then we do some other things like some limited intermittent fasting and emphasis on strength training, which augments that approach as well.
Okay, yeah, that's really interesting because we don't really have a lot of folks talking about the emphasis on cholesterol being the problem with the blood sugar coming up. You know what I mean? The balance.
There's the balance, yes.
It's different than what we hear a lot of.
Right.
You use continuous glucose monitors, also known as CGM, to help patients lose weight and improve their health. So can you explain what a CGM is and how does it work? Is it painful?
No, it is not painful. You put it's those devices you see on the back of the arms of diabetics. There is a small sensor that is put under the skin into the subcutaneous tissue. That sensor picks up the blood glucose in the area and then sends it to an app on your phone. So you can see your blood sugar 24/7. So these devices have been out for 15 years, originally used by diabetics to dose insulin, but tremendous tools for people that are pre-diabetic or have risk factors for diabetes, like being overweight or a family history. And I use them initially diagnostically in my practice to look at blood glucose physiology because it gives you a better picture than just an A1C or a fasting blood glucose. And then we use them therapeutically for people to help guide their low carb diet. If I can tell you just, very, very briefly kind of the physiology of what's going on here? Is it okay if I?
Oh, yeah, that'd be great.
Okay. So what happens is when you eat a carbohydrate, whether it's sugar or complex carb, potato, pasta, basically any carbohydrate other than fiber, your blood glucose rises. Your pancreas releases insulin, and insulin is that signal to let that blood glucose into your organs, like your muscles. And so far, so good, because our muscles and the rest of our body organs need energy. But what happens is if your blood glucose is persistently high for a period of time, as it is in a majority of Americans now, that with these high carb diets, with 60% of Americans, adults being overweight, then the blood sugar is elevated for a prolonged period of time. So the pancreas keeps kicking out this insulin because insulin is the key in the lock to allow that blood glucose into your organs. And when I say organs, think muscles. It's kind of the easiest analogy. But after a while, those organs have all the energy they need. Blood sugar has been plentiful. They've stored extra blood glucose within the organ itself in a complex glucose molecule called glycogen. And so those organs stop listening to the signal from insulin. That's what insulin resistance is. Basically, the organs are saying, insulin, pancreas, we aren't going to listen to you anymore. So what happens then? Well, that blood sugar rises, and because blood sugar is toxic, it has to go somewhere. So it goes to the liver and it gets converted to fat and then largely deposited around our middle. So that's the reason why excessive carbohydrate intake, the physiology, causes weight gain. Some of that fat may stay in the liver, causing a problem called fatty liver disease, which I think many of your listeners have heard of. So fatty liver disease really is a little bit of a misnomer. You hear fatty liver disease, you think, oh, that's got to be from eating too much fat. But actually, most fatty liver disease is from eating too many carbs. So when you go to a low carb diet, and I'm not talking about an aggressive, you got to be in ketosis all the time. I'm talking about a moderate low carb diet, which for me is 35 to 50 grams a day of carbs for my patients, making sure we get adequate protein as well. Then what happens is you reverse that process. Those organs don't see as much plentiful blood sugar around, so they start looking for another source of energy. And what's that source of energy? That fat that we all have around the middle. So that fat starts getting broken down, and that's used for energy. And that's when weight loss improves and blood sugar comes down, and the risk of all those pre-diabetic, diabetic, hypertensive, obesity-related issues begin to resolve.
So I hear a lot about insulin resistance, but I've never heard it in my doctor's office.
Yeah.
How do you find out if you're insulin resistant? Is there a test for it?
Absolutely, there's a test for it. So people will get their cholesterol checked twice a year, but we never do fasting insulin levels. I do fasting insulin levels on every patient. So you can get an insulin level, and there's a relationship, as you might guess, between where your insulin level is and where your blood sugar is, because as we just discussed, insulin pushes that blood glucose into your organ. And if your insulin level's at a certain level, it should be driving your blood glucose down. And if it's not, it means you got insulin resistance because the pancreas keeps pushing out this insulin, but the organs are not responding and the blood sugar is not going down as quickly as it should. So if you get a simultaneous fasting insulin level and a simultaneous blood glucose, you can look at that relationship. And there's a specific parameter called, the acronym is HOMA-IR, HOMA-IR. It's the acronym for the fancy term, which is homeostatic model of insulin resistance. But you can calculate an exact level of insulin resistance in any patient given those parameters. And I do it in every patient. And again, I think this test for the majority of Americans, it's not that I don't believe in cholesterol. People can have cholesterol problems and you need to pay attention to that. I get that. But for the vast majority of Americans, this is a much bigger issue. And so I calculate a HOMA-IR in every one of my patients. And then after we make when we start, and then after we make lifestyle changes, we recheck it 3 or 4 months down the road again. And, we bring that insulin resistance down with this program, which is basically low carb, a little bit of intermittent fasting, and then we'll talk about emphasis on strength training because it also reduces insulin resistance.
Now I'm going to ask, how does the CGM actually help you lose weight?
Okay. So it's in conjunction with this low carb approach. So I use CGMs initially diagnostically in my practice, as I think I mentioned. So I have patients come in. Patients usually come to me because, they're concerned about their prediabetes or being overweight, or they have diabetes in their family, or now they found they're having hypertension and GERD, and they've been told they have fatty liver problems. So that's kind of my demographic. And as we talked about, it's, largely middle-aged and older women because women are smarter about addressing their health than guys are a lot of the time. So I initially use the CGMs diagnostically. So we'll put a CGM on the back of a patient's arm, and I tell them initially, don't change your diet for 7 to 10 days. Let's just see where you've been living in terms of your blood glucose physiology for these many years. And so then we see the patterns, whether their averages are high, whether they're spiking high, whether there's variability, which we can get into, can lead to fatigue and brain fog type issues. But first, we just have them wear a CGM for a couple weeks, and we use that data then to begin to see where they are and put together a plan. So it's also during that first 2-week period that I do this insulin evaluation as well. And then we get back together with patients after a couple of weeks and we analyze that data and we put together a program that will help them reverse that.
Let's say that I look at a list of metabolic diseases and I realize that I fit into what you're talking about. If I go to my doctor, she's most likely to hand me a prescription for blood pressure or cholesterol, whatever. And you're saying that there's a different way to treat all these diseases?
I don't know if it's necessarily a different way. I'm not going to say what your primary care doc is doing is wrong, but it's a disease management model. It's we're gonna see till you have disease. We're gonna wait until you have disease, and this happens all the time, every day. It's like, oh, the doc says your blood sugar's a little bit high. We'll keep an eye on that, rather than being proactive. Prediabetes can be reversed so that you never become diabetic. Once you progress to diabetes, I get lots of patients off diabetic medications, but they're still going to have that underlying insulin resistance. I have many, many friends that are primary care docs, and they're just in a tough situation now. I'm gonna reflect back when I got out of residency. Docs were still like, they were small business people in their own practices or small group practices. Basically, they were working for themselves. That's completely changed in the last 30 years because now the docs generally are employees of health systems and their schedules are regimented. You get 20 minutes and they're told they have to make sure they document. They're in the computers documenting so that the service that they're providing can be billed at a certain level. And so they unfortunately, and it's frustrating to them. I think you probably know a lot of primary care doctors feel that they can't really serve their patients the way they want to serve their patients. But that's all they have time for. Let's tweak your insulin. Let's maybe start metformin. Oh, we need to go ahead and increase your blood pressure medicine. So my practice is just kind of an alternative to that approach where we do have time to dig into these issues and talk about the lifestyle issues that I think are really, really important. So I'm not disparaging the primary care docs. They're doing the best they can given the current healthcare model that exists.
And if you have hypertension, as an example, obviously you need to take medication to control that. But if you then do the lifestyle changes, perhaps you can reduce that or come off it at some point.
Yeah. The word is de-prescribe. I love it when I can de-prescribe patients, or I can call a primary care doctor.
I like that.
and say, they don't need they don't need their metformin anymore. They don't need their antihypertensive anymore. They've lost 25 pounds. Their blood sugar physiology is improved. It's a great approach. And I do think we overprescribed. I think statins are an example of overprescribing. I mean, I've had patients that come in and they've got their blood sugar on their CGM spiking to 230, but their last visit with their doc focused on their cholesterol of 210, which I think quite honestly is almost immaterial. just as an aside, if you have a high cholesterol, and again, I believe high cholesterol can be a problem. I don't think it's nearly the problem that bad blood glucose physiology is for the majority of middle-aged Americans. But cholesterol can be a problem. But sometimes you can have a high cholesterol, and your type of cholesterol, the bad cholesterol pattern called an LDL, can be relatively harmless. So, one thing your listeners may want to consider if they've been told they need to go on a statin and their resistance, I'm giving you questions that people can throw at their primary care doctor that the primary care docs might not appreciate. But the other question is, well, can I get my subfractions of LDL done? Because you can have you can have a cholesterol 240, 250, 260, but you could have an LDL subfraction pattern that is harmless. Basically, without getting too wonky, it's the big fluffy LDL as opposed to the small ping pong ball LDL. And it means you really aren't at risk. And this is important for my practice because it means, we can tell you to keep your carbs low and your protein high, and we don't have to worry about your fat as much.
I'm just going to inject in there that I did ask my doctor for that, and she said she didn't know anything about it. So we didn't do it.
She didn't know anything about it?
That's what she said.
You mean the small particles versus
the fluffy? Yeah. I didn't have the right terminology probably, but I asked about that, and she said, I don't know anything about it. So we didn't test it.
Part of that is, that's too bad she didn't know anything about it. But I also like a doc that knows their limitations. And
I
if they don't
absolutely
know
would much rather her say that than
to say I don't know. But then there are alternatives if you want to pursue it. I have patients, not a lot of patients, but I have a local lipidologist, a cholesterol expert that I will send patients to occasionally when they come in, because is a small group of people that can have high cholesterol on low carb diets. But I will tell you, in general, the pattern that I see in terms of change in cholesterol when I put people on a low carb diet, and again, we say, keep your carbs under 50, get your protein at least 100 grams a day. Usually we actually personalize that some. And I don't worry about fat a lot. We do talk about good fats and bad fats. Seed oils are bad. You want to avoid processed foods that contain a lot of those inflammatory seed oils. And, let's gravitate toward, cooking oils with omega-3s as opposed to omega-6s. Let's talk about saturated fat that's in meats. And if higher quality meats are an option, basically grass-fed, or range-fed animals, then so we do talk about that. But in general, it's keep your carbs low, keep your protein high. We aren't going to worry about that as much. And I'll tell you the pattern that I see, and it's not every patient's, but usually the cholesterol doesn't change a lot. The LDL doesn't change a lot. Sometimes HDLs, because you're getting more fat in your diet, will go up. The good cholesterol will go up a little bit. And triglycerides, which is the other kind of fat in the blood, plummet on low carb diets. So that's not intuitive because you're eating more fat and you think, basically my triglycerides, the fat in my blood is going down. Why is that happening? Same reason we talked about earlier. Triglycerides are formed from the conversion of blood glucose to fat in the liver. That's the building block process for triglycerides. And when you cut off the substrate, when you decrease blood glucose, triglycerides go down. And I've had patients that have had triglycerides of, anything usually over 150 is considered abnormal. I've had patients that have had triglycerides of 250, 300, and we put them on a low carb, high fat diet, and their triglycerides go down way under normal, sometimes way under the high limit of normal.
How do people get a CGM if you're not diabetic?
If you aren't diabetic, yeah, we'll talk about that. So first of all, if I can mention, so then the program going forward is usually some combination of low carb, high protein, intermittent fasting. I'm not talking about days of fasting. I'm talking about 14 or 16 hours overnight. And then the third component, before I answer your question that I want to go on to is the third component is strength training. So what's a little bit different about me is I tell my patients not to worry about their fat so much. I tell them not to worry about their cardiovascular training as much as they do. Because strength training, I think, especially for middle-aged and older women, it's where it's at. I do tell my patients to follow the American Heart Association guidelines for cardiovascular fitness. If you do that and you get to your 80% heart rate max, you can do that in 75 minutes a week. And if we all just have 4 or 5 hours a week to work out all together, that means you can be spending 3 or 4 times as much time on strength training, which is absolutely critical. A career in the emergency department, seeing the frailty that some people end up with when they get into their 70s and 80s and beyond, to the point where they even lose their mobility, not because they've had a stroke or a neurological problem, but just because they don't have enough muscle mass in their legs to get up and around. So again, the 3 components of the stool: low carb, high protein, not worrying about fat so much, intermittent fasting to a limited degree, and then strength training. Okay, thank you for letting me fit that in.
No, that's great.
We love to
Yeah.
hear about strength training. We're all about that for sure. So that's cool.
Good.
So, in the intermittent fasting, you say you do basically time restricted 14 or 16 hour.
Yeah. I mean, I have some patients that want to do more. They want to go to an OMAD, a 1 meal a day approach. But most of my patients, it's 14 or 16 hours overnight. And, you got to live your life. If you're having a special occasion, maybe breakfast on a weekend with your family or going to a wedding where it's that's fine. You don't have to do it every day. But in general, what reverses insulin resistance after low carb is making sure you're fasting some. And then I didn't mention this, but the reason strength training is helpful is because if you can increase your muscle mass, you increase the quality and the receptivity of those insulin receptors on your muscles. You soak up more insulin, decrease insulin resistance, more blood glucose. So it helps with this process as well.
Okay, that's good.
CGMs?
I do want to know how we get a CGM.
Yeah, okay.
There's a lot of things we could talk about, because that brought up something I also want to get back to, but let's talk about how to get one first.
Okay, so I am gonna plug a couple things that I do. So CGMs have gone over the counter in the United States about 4 months ago. There is a Dexcom. The name of the company that makes them is DEXCOM, and the name of the over-counter brand that they sell is the Stelo, STELO. And an over-the-counter CGM is about $50 for 2 weeks. Again, I know it's an investment for some people, but in terms of the data that you get, the seeing your patterns, basically getting a fasting blood glucose every morning, then I think it's well worth it. So I have a website. I have a medical practice website, which I'll maybe talk here toward the end, but I also have a website that I've developed in the last 4 months for people to go to and get over-the-counter CGMs, no prescription required. And that is CGM-Doctor, the word DOCTOR, CGM-Doctor.com. So again, you can just order a CGM there. And then, though my medical practice is limited to Ohio, Indiana, Florida, and Arizona, where I'm licensed, I have health coaches that I've been working with for 7 years who have become experts in CGM data interpretation, and they can provide health coaching to patients either in those states or any other states. But basically CGMs are over the counter. I would encourage people to look for some support in terms of how to use it and interpret your data. And this is where I'm going to make a plug for the book, The Continuous Glucose Monitor Revolution, because really the program that I've just described, everything you need to know is in this: how you use it initially diagnostically, then therapeutically to guide your low carb diet. So, get a CGM, but, understand how to use it effectively.
You said it's $50 for 2 weeks, so then you mail it back? Is that how it works?
No. So I probably wasn't clear on this. So you put this on the back of your arm. Again, not painful. You wear it for 2 weeks. You don't even know it's there. The data is transposed to an app on your phone. Okay. And you can see your data in real time. If you choose to share that with a health coach or a clinician, you just put in a clinic code in the app, and then I get online and I can see all my patients' data. My health coaches can see the data for all of their clients as well. So it's basically, hooked up to the web. so that we can review and interpret that data really in real time. And I don't bother my patients in real time. It's not like I'm going to call them up on a Monday morning and say, "Hey, what happened Sunday afternoon?" I don't do that. But if things are going off the rails over a period of a week or so, then we do have a conversation. We do reach out and say, what do we need to do to address that? A lot of time it's situational stress issues, either something at home or at work or whatever. But that data could be followed in real time.
And you said it's just for those 4 states, or with your practitioners, it's beyond that?
Yeah. So my medical practice, which I'll mention, I'll make a plug for that, is metabolicmds.com. So the word metabolic, MDS plural, is I'm licensed in Ohio, Indiana, Florida, and Arizona. I do almost all my work by telemedicine now. And so I can see any patients in that state for those states for my full program. In the rest of the United States, in the other states, CGMs are available over the counter through that CGM doctor website. And my health coaches who, are not prohibited from working in those states because it's not a medical licensure issue, they can provide support to patients. So unfortunately, I can't work in those other states because I'm not boarded by the state medical boards in those states.
We have listeners all over the world. So what would someone who's outside of the United States do?
So usually in many other states, like in Europe, I know, and in the Middle East, that the CGMs are available over the counter. They've actually been available over the counter in Europe for a number of years, kind of a less restrictive policy. So just, look up Dexcom, Stello. The other brand is made by a company called Abbott, and it's called the Lingo, Lingo. And your listeners should be able to find one. And I can't tell you, I don't know specifically if it's every country, but I know that they're more widely available over the counter throughout the world than they had been until recently in the U.S.
Let's go back to the 2 weeks. After 2 weeks, you remove the CGM, or do you pay another $50, or do you get to keep the thing and just need to add new sensors or something?
So it's not, yeah. So that CGM is disposed of after 2 weeks. If you want another 2 weeks worth of data, you need to go ahead and buy and put another one on. And I have a range of patients. So in my practice, I use those therapeutically in subsequent periods of time. So we use that to help guide their low carb diet. And people kind of build this database of, if I eat this, that's going to happen. If I, eat that, I'm going to be okay. So people then use them therapeutically going forward to guide their diet. Of course, I follow that diet. And I have a range of people. Most people want to wear one for a few months to get a good understanding of what's going on. I've had patients that once they have a CGM on their arm, they never want to not have a CGM on again. They really become fascinated with it and it's integrated into their lifestyle approach. But I have other patients where after a couple months, that they have a good idea what's going on. They know what they need to eat and what they need to avoid. A lot of times then they'll just use one intermittently once every 2 or 3 months to make sure they're staying on track. So it doesn't need to be a continuous thing.
Okay. All right. That makes sense. Oh, let's go to the medication. So you said you use the CGMs, but you also use the different weight loss medications that have come out. Can you talk about that for a bit?
Yeah, so there's an awful lot happening in that space right now, as you're probably aware. GLP-1s are here to stay. The genie is out of the bottle, so to speak.
Yeah.
And people are going to use them. There's a huge expense issues in association with them. Those may be accelerating because the alternative medications may become unavailable in the near future. So the cost of these, have been if people don't have insurance, and insurance coverage is limited just because, companies and the government has not widely covered them because of the associated costs. There are those limitations. If people choose to use them, I suggest a couple of things relative to the CGM utilization. First of all, to just jump on board with the GLP-1 and, basically become dependent on it for a lifetime I think is not a good approach. Any medication, if you can avoid using it, you should avoid using it. But there are people that want to use it on a limited basis to get a restart or work through a plateau. So I do accommodate that in my practice. Unfortunately, what a lot of what's going on right now is, and I'm just going to say it is that some practitioners are pushing these medications, pushing people onto high doses and making them dependent for a lifetime on the medication. This
Now,
is the way I
we're
think.
talking about things like Ozempic, right?
We're talking, yeah, there's a specific brand names are Wegovy, and the other one is Zepbound. Okay. Ozempic is the diabetic version, which is only available to diabetics. Monjuro is the diabetic version of Zepbound. And then there are the other medicines which are not FDA approved that are out there and prevalent on the internet called compounded medications. So their availability may become limited here in the very near future.
And there's some significant side effects
Yes.
once you have higher doses.
Right. Even at low doses, they can occur, though. Unfortunately, I haven't seen it. So the approach I take is what we call microdosing, where we try and keep people on lower doses for limited periods of time. It's the old Stephen Covey approach of begin with the end in mind. And what's the end in mind? The end in mind is not one to be dependent upon medication for the rest of your life. So I like people to do a CGM trial first, see what's going on with their blood sugar physiology, because these medicines, we're diabetic medicines, so they do lower and stabilize your blood sugar. That's one reason they're helpful at losing weight. But they also have a direct effect on hunger, and they also have a direct effect on keeping your stomach full for a longer period of time. But the way I believe they should be used is with first a full metabolic health evaluation before you start the medication. And that's the process that we just talked about, using a CGM for a couple of weeks, checking your fasting insulin level, talking about, low carb intermittent fasting and strength training, and then using low doses of the medications for limited periods of time, this microdosing approach that I mentioned. So these medicines are titrated up over time, usually are at a certain level for a month, followed by increasing that to the next level for a month. And then if you keep going, increasing again 4 weeks later and continuing to increase. What I try and do with my patients is I try and keep them on the first dose or two, the lower doses, because, the higher you titrate up, the harder it's going to be to titrate down and off. So you stay at low doses, you institute the lifestyle changes that we talked about. And then as you're titrating off, you reinstitute the use of a CGM to help guide the diet, just like we talked about previously, so you can get off the medications without any significant weight gain. So I was doing metabolic health and, this low carb approach well before the medicines ever came out. I use the medicines now. And quite honestly, one reason for that is that I'll lose people, because there are people that are just looking for medicine. And so we talk, and I don't want to lose them to somebody that's just going to put them on the highest dose and want to keep them there forever. So I will put them on one of the two lower doses, and then we'll work on these lifestyle changes with the plan to get them off.
Something that when we were talking earlier that about the different things to do is bone health. One of the things that as older women we pay attention to is bone strength, density. So I know sometimes people say, well, if you're losing weight, you're really just messing up with your bones. I don't know. Do you have any thoughts on that?
There's no question there's a relationship there. When you're losing weight, you're losing both fat and muscle mass. Nobody should be on these medicines if they aren't getting their protein and strength training adequately. That's a big deal. And of course, osteoporosis or your bone health relates to your degree of muscle mass, because with a larger muscle mass, you put a little bit more stress on your bones, and that helps you maintain the calcium concentration in your bones. So there is an absolute relationship. We're all losing about 7% of our muscle mass a decade as we get older anyway. It's very important to be strength trained. This comes back to my emphasis on strength training over cardiovascular. It's very important to be strength training if you're on these medications. for a variety of reasons, but one is your bone health, and the other is this risk of frailty. As you get older, and losing muscle mass. So anybody that's even thinking about these medicines needs to be in a strength training program and making sure they're getting adequate protein to support that muscle mass and bone health.
That makes sense.
Good point.
Is there anything we haven't asked you that we should know?
I think we've covered a lot. I'm appreciative of, having the opportunity to discuss all these different areas. I think it's important. I think people need to empower themselves related to their health because unfortunately, a lot of the forces that we see are pushing us in the other direction. The food industry, that's getting a little bit of attention these days with the Make America Healthy movement again. But the food industry pushes us toward processed food. The medical industry really has a disease management model. I think up until now, the government really hasn't helped provide good guidance either with the food pyramid approach that we've been supporting for over 50 years. So I think that the message is that nobody cares about your health more than you do. You need to empower your health, and the way you empower yourself to improve your health. And the way you do that is with knowledge. I think CGMs are a great tool in that regard because data is power. And when you see the numbers, then it's very instructive. One of the chapters in the book is CGMs Change Lives. And that is in the scenario of, your doctor may have been telling you to watch your weight for years, maybe without a good plan to help you do that. But, it's a typical doctor, eat less and move more. So, but once you see the data on your phone, the way my patients have put it, you can't unsee it. Once you've seen that you're spiking to this level or whatever, and you see the variability, you see the high averages, you can't unsee it. And this is why I think, as an aside, low carb is not that burdensome. Calories in, calories out, I don't think is sustainable, but low carb, I think, can become a lifestyle. Where you really, it doesn't bother you to eat those foods that you previously enjoyed. I've ruined my patients in terms of, maybe ever eating a donut again or a piece of pizza. It's not that they won't have it, but they're going to be thinking about what that graph is going to look like relative to that because they've had that experience. And quite honestly, I think that releases strain or releases stress or the burden because some of those things that you used to, kind of agonize over whether you should eat it or not, it's now off the table. You don't even think about it, or you don't think about it very often. So that's why I like this as a very sustainable approach.
Can you remind us again the name of your book?
Okay. So the book again is The Continuous Glucose Monitor Revolution. It's the best-selling book on Amazon on CGMs for non-diabetics. You can also just Google my last name in Amazon, Kolodzik, Kolodzik, and the book will come up. And again, the website for over-the-counter CGMs is cgm-doctor.com. And for your listeners that are in Ohio, Indiana, Florida, or Arizona, if they'd like to work with me and in my medical practice, that website is Metabolic, the word Metabolic, MEPABOLIC, MDS.com.
And you also have a podcast, right?
Yeah. I have the Metabolic MD podcast has been coming along as well. We're now in about the top 10% of podcasts as well. And we talk about all these issues as well as a number of other issues, what's going on in medicine today, basically providing people insight as to how they can empower themselves to use the system to their best advantage to get what they need. We'll do things like, talk about, the LDL subfractions. We'll focus more on strength training workouts. How do you go low carb? I'm going to give you another aside here. If people haven't tried this, if any of you are doing Chat GPT or one of the AI systems, I've recently, just in the last couple weeks, picked up on asking Chat GPT for low carb, high protein meal plans. And you ask Chat GPT for 5 or 7 days of low carb. You can put all the parameters in. I don't follow calories that much as you can guess, but I want I want to get, less than 50 grams of carbs. I want to get more than 100 grams of protein. I want to keep the cost to this amount, et cetera. And it'll give you a meal plan that, you might not want to follow exactly, but can be very useful in providing you some guidance.
Great idea. Oh, quick question about the food, and I know we're wrapping up here, but fiber. I assume we still should be worried about or concerned about getting enough fiber.
Yeah, but so the term I use when we're counting our carb, that 35 to 50 gram number is that is net carbs. So
Okay.
fiber does not count in that. The term I use is fiber is free. And when you go low carb, you end up usually getting more fiber because a lot of the carb substitutes are fiber. If you want to have a taco, there's tacos that might have a cauliflower base that have a higher amount of carbs than the that have a lower amount of carbs but a higher amount of fiber than the corn products out there. So, fiber is free, fiber is great, and it can augment your low carb approach.
Okay, great. Thank you. Well, thank you so much for talking with us today. It's been really very educational.
It's been a pleasure. Yeah, I appreciate you giving me the opportunity to get the word out about this type of lifestyle, and then a little bit on how to use the medicines prudently because that's a big issue right now. So I just appreciate your support of helping me reach a wider audience.
Yes, thanks so much. Really appreciate talking with you, and we'll talk again soon.
All right. Thank you.
Bye-bye.
Bye.
Dr. Paul sure had a lot of great information, and I thought it was really interesting, his 3-point guide to getting your insulin under control.
What were they?
Well, the first thing is his low carb, high protein, carbs under 50. I think that's net carbs under 50 grams a day.
Yeah, and net carbs are your total carbs minus the fiber.
Fiber, right. So it's low carbs and then high protein around 100 grams a day. So that's the first point. Then the second point is to do intermittent fasting. And he started to say 16-8, meaning 16 hours fasting and 8 hours eating window. But then he changed it to 14-10, 14 hours, 10 hours eating. I'm not sure.
I thought maybe that was for starting out because I think the 16-8 was his
preferred.
Yeah. I think that was, yeah.
And then the third, of course, something that we talk about all the time here on Becoming Ellie about strength training and to increase those muscles because over a decade, over 10 years, he said 7% muscle loss every decade. So just to stay even, you've got to keep working out and doing strength training.
Did he say strength train 4 times a week?
I don't know. 4 times a week is a lot for me. I know that. Unless I break it up and I just do, like one day I just do arms and upper body, and then another day I do lower body, then another day, upper body, then lower body. You know what I mean?
Do the push-pull thing. Yeah.
Like breaking it up. But if I do everything, I wouldn't be doing 4 days a week. It's just too much for me.
Absolutely. I get it. Yeah.
I guess it depends on how you strength train, what muscle groups you use.
I don't know why I thought he said 4 days a week because I was like, oh, that's more than I do.
And I do think it's how you do your strength training, because recovery, especially as we age, takes a little bit longer than it used to for like everything.
So my boyfriend just said to me recently, he said, I think there's this thing that when you're over 50, you're supposed to do more recovery.
Yes.
I said, yes, that's true. Did you not listen to my podcast?
Maybe he doesn't. He goes, well, why should I? It's for women over 50, right?
Right. No, he does not listen, I'm sure. I could say anything I want.
Yeah, well, it all of a sudden hits you. Gee, I need a little more recovery time than I used to. That's for sure. But
yes, and that's true with a lot of things.
Yeah.
So, the whole thing about CGMs, the continuous glucose monitors, I've been interested in them for a while because I've listened to a lot of podcasters talk about them, and this whole biohacker group, people are really into them. But what I did not know was that you can now get them over the counter in the US. I thought that was very interesting.
Right, right. Well, I've seen it online more than I don't think I've seen anyone, wearing it, but then maybe they're wearing longer sleeves because they don't wanna brag about it or whatever. But, like avoiding diabetes or even prediabetes is, getting over the whole insulin resistance thing and being insulin sensitive is so
Yeah,
important these days.
yeah, I really liked too how Dr. Paul explained insulin resistance and why it mattered, and that you can be tested for it.
Well, we had talked a little bit about, or he talked about HOMA-IR, and you looked that up for me again because I couldn't take notes well enough. I know IR was insulin resistance.
Homeostatic model assessment of insulin resistance. And it's basically the formula they use to estimate what your insulin resistance is. It has to do with fasting glucose and fasting insulin and this whole mathematical thing, but that's what that stands for.
So you need a blood sugar level in order
You
to
need
do
to
that?
know
You
your
need a blood
fasting
test?
glucose, which would be a blood test, and your fasting insulin, which is also a blood test. And if you have both of those numbers, then you can figure out what your insulin sensitivity is
With the formula.
with a formula.
And
Yeah.
you can just Google the formula, it sounds like,
Yeah.
as long
Or
as you have the blood
as
levels.
long as you have that, yes. The point about insulin resistance, I gather, and again, I'm not a doctor or anything, but is that if you have insulin resistance, it puts you at greater risk for developing type 2 diabetes. And what he kept talking about was the metabolic syndrome, which is both diabetic and cardiovascular disease.
All the bad things that we don't wanna get, those, metabolic diseases. It was interesting that $50 for 2 weeks
Yeah, that was for the sensors, yeah.
for the sensors and the readings, yeah.
If I were going to do that, so like he offers help with doing that, which to me is appealing. If I'm going to go out and buy a monitor, I would want some help with assessing it, especially at the beginning. Like,
Right,
what do I do with this information?
right. It's not just like wearing one of those watches and go, "Oh, okay, that's how fast I walked today," or whatever.
Right. Yeah, yeah, yeah. Or look, my heart rate is this.
Yeah,
Or
yeah,
look,
well
I love how I look at to see how I slept. Like, I don't know.
Yeah,
Look, I had a good night's sleep. Or look, I didn't have a good night's sleep. And
yeah, you pretty
yes,
much can tell when you
I
get up.
actually knew that because I lived it.
Yeah. Well, it's amazing when you exercise how well you sleep the next night, right? I mean,
Yeah,
at least that's what
often.
happens for me,
Yeah, it does
I've
help.
noticed that. Well,
Yes.
I'm off track here. We're still talking about Dr. Paul, and, he did have a lot of great information between his book and his website and, some of his coaching things. I
Yeah.
just think that he's, full of great information that's helpful.
Yeah, I learned a lot.
Yeah, I did too. Some people like to try different ways of eating, whether it's keto levels of carbs or
Yeah, I liked that he was not at a keto level. I think people who do keto are at 20 grams of
yeah,
fiber or of
maybe
carb
22. Yeah.
something with again, they're net carbs, so you get the fiber, but fiber's free.
Well, I know some people do really well on keto, but it's very difficult for me to have that amount of discipline and then I feel deprived and it's like I could deal with 50 net carbs for sure.
Yeah,
50 net
and
carbs is realistic
I
to me.
actually looked to see if, because everyone talks about the Mediterranean diet. You
Yeah.
can easily do the Mediterranean diet, still do a low carb, high protein diet. I want to just check on that because people are always saying you should eat that.
Now, do you use like MyFitnessPal and put your food in there so you can see what your carbs ended up for the day and your protein?
When I log food, I use Chronometer.
Chronometer.
Yeah, I used to use MyFitnessPal, but I really like Chronometer.
I'll have to try that because I've tried MyFitnessPal for so many years and they keep changing the app, like the world keeps changing and I keep resisting.
Yeah, yeah.
But I'd like to try something else that's a little easier to enter your food in.
So it's very easy. It has the whole barcode thing that
Nice. Yeah.
you can swipe the barcode and it comes up with what a serving is and all that. That's
And it
nice.
saves your meals real easily.
Yeah,
Like
you can
prompting you. Yeah.
Yes. I started using it when I was doing a thing where I was using the Fitbit food tracking system, and the Fitbit's food tracking is horrible.
Yeah. Yeah.
So I was going into Chronometer and entering my recipes and my meals and then transporting that to Fitbit. And then I thought, well, this is stupid.
Yeah. I gave up on Fitbit a couple years ago. After Google bought them, I just felt like, man, this is not going the way I want it.
Well, they wiped out all our data.
And our communities. I really like the community of
I
it.
had years of data in Fitbit, and last I looked, it was down to like 2 years.
I think you and I are both a little bit data junkies. It's nice to compare, how you did in the past and how things are going, but
Fitbit doesn't care anymore.
no, things keep changing.
Yep. So anyway, yes, I use Chronometer, and I do try to pay attention to how much protein I'm eating and how many carbs. And, and I always do still look at how many calories I ate.
Yeah. I don't really worry about the calories so much. I think more of the protein, really trying to focus on getting some of that because it's easy to slack off on that. It's just.
Yeah. I don't mean to say that I'm worrying about the calories, but I do look, today I ate 1,800 calories, and yesterday I ate 2,500 calories because I ate those brownies or whatever.
Right. Or you went running and you were really hungry after.
Yeah, that too. Yeah. Well, now that we've wandered way off of topic, if you are listening and you have any thoughts on our talk with Dr. Paul, please let us know. Have you used a CGM? Have you done a low-carb diet? Do you log your food in anywhere besides?
Yeah.
We'd love to hear from you regardless of whatever it's about. Please let us know.
Yes, please let us know. You can leave us a message at becomingellie.com, and you can also find us as Becoming Ellie on Facebook, Instagram, Pinterest, YouTube, and LinkedIn.
Also, please consider joining our private Becoming Ellie Facebook group.
It was great talking with you today, Jill. I'm looking forward to our next episode of the Fit Strong Women Over 50 podcast.
I am too. See you next time. Bye-bye.
Bye.